Welcome to our cutting-edge online point-of-care ultrasound fellowship program. We are excited to invite you to this pioneering fellowship designed to empower healthcare professionals with advanced skills in acute care ultrasound. As a participant, you join a diverse global community committed to transforming patient care through innovative ultrasound practices in critical and emergency settings. Our comprehensive fellowship is meticulously structured into 2 immersive modules, each spanning 24 weeks. Whether you're just beginning your ultrasound journey or you're a senior clinician refining your expertise, this program is tailored for you. Our curriculum bridges the gap between theory and practice, providing an evidence-based, clinically relevant approach to ultrasound education. You'll explore critical applications, including shock volume assessment, cardiac function, and sonal anatomy, lung normality and abnormality pathology, several acute care procedural guidance, several real-life practical case scenarios, and much more. We understand the demands of your profession, which is why our fellowship offers unmatched flexibility. All interactive sessions are recorded and available on a user-friendly learning platform, allowing you to revisit key insights anytime, anywhere. Through expert-led lectures, real-world case discussions, and journal clubs, you'll gain a profound understanding of ultrasound applications, backed by the latest evidence. Our esteemed faculty consists of renowned experts dedicated to guiding and mentoring you throughout your journey. With their support, you'll enhance your skills and stay at the forefront of ultrasound innovation. By the end of this fellowship, you won't just master ultrasound techniques, you'll become part of a global network of like-minded professionals, fostering collaborations, knowledge exchange, and continuous learning in acute care ultrasound.
So good evening, good afternoon, wherever we are in the world, for everyone. It's my pleasure to moderate this session of the live webinar for this batch of program of the fellowship critical care ultrasonography as part of the point of care ultrasound focus in acute care settings. We are now in the advanced critical care module, and this is the week number 15. And as we used to do with our fellows that are joined this program, we are meeting live every 4 weeks. And this is the week number 15. And we assigned this live webinar to cover one of the topics, which is very, very important in critical care medicine in general, and one of the essential tools of point of care ultrasound that we frequently, maybe daily using them in acutely ill patients who are presenting with shock. We have the pleasure to be today having a constellation of well-known speakers from UK and from United States, and also our fellows, which they are keen to present their own cases. I'm very pleased to have tonight Dr. Nebras Bugrara from United States of America. He is a professor of anesthesia and critical care medicine at Albany Medical College. And he's also director of critical care ultrasonography with a lot of publications in point of care ultrasound. And he taught us in a week how we use the subcostal view in different ICU and perioperative situations, easy protocol. We are very pleased to have also Dr. Avinash Jah, who is a consultant critical care medicine with a lot of enthusiasm in point of care ultrasound, particularly the brain ultrasound. And Dr. Avinash is consultant, as I said, critical care medicine in Preston, UK, in Lincolnshire Teaching Hospital. Also, we have another critical care consultant working in London, Dr. Hazim Lashin, and he is working in Parts Health NHS Trust, part of Queen Mary University hospitals. We are very pleased to have Dr. Anwar Yus from Al Yemen, and he is a critical care consultant and we are very proud to have him with us as one of the fellows. And Dr. Ala Ghanim from United Emirates, and he's also critical care specialist in Abu Dhabi. And both Dr. Anwar and Dr. Ala will present their own cases of Pocus in hemodynamic instability situation. As we used to do with every meeting, I just remind our fellows that this is your chance to ask your questions. If you have any question about the previous weeks, if you want to bring your cases to present, like what Dr. Anwar and Dr. Ala will do today, and then it's a great pleasure to have all of you again. And without any further delay, let me give the mic to Dr. Nibras Bugrera to start presenting the first real-life experience in shock case with point-of-care ultrasound. Prof. Nibras, mic is yours.
Thank you very much for inviting me. It's my pleasure to be part of this amazing group. And today, I don't have a lot of time. You gave me only 15 minutes, so I'm going to start the watcher right now. And I'll talk about real-life cases with sepsis and septic shock. Disclosures, I sat at the medical advisory board with Philips, and it has nothing to do with this talk. So 2020, we got hit with COVID. It wasn't a pretty picture. At one point, we went from few ICU patients to 79 intubated COVID-19 patients. And the Department of Internal Medicine asked that if we can step in as anesthesiology department and help and take one of the services. So I'll share with you today 1 week or 8 days service that we did with COVID patients. As you know, COVID is sepsis, and sepsis is basically a crazy immune response to an infection, and that immune response can attack organs and cause organ failure. And in the ICU, in our cases, there was a lot of lung issues with ARDS, with COVID, obviously. Also, there's septic cardiomyopathy with circulatory failure, acute kidney injury, and multi-organ dysfunction. Obviously, the ARDS needs a consultant to look and manage the ventilator. But then we looked at the circulatory failure and the acute kidney injury, and we thought there are only 3 buttons to choose of: volume optimization, vasopressors, and inotrope, and maybe some procedures. So we thought about expanding the service by training our surgery residents. So this is a surgery resident who took 1 day training and just obtaining a subcostal view. We get her into the room, we get her in there, we close the room, and then the resident will do the exam with the subcostal after 1 day of training. You can see here this patient was hypotensive. You can look at the heart, it's hyperdynamic. The IVC is plethoric. And shortly, we're going to look at the aorta to make sure it's not the IVC. We didn't confuse both. So this is the aorta. And then the next step is to look at the upper lungs. And you can see here, there's a bunch of B lines. So the assessment for this patient is not to give fluid. It's a distributive shock, well resuscitated. We started norepinephrine, and the resident took around 4.5 minutes to get that exam completed. Again, this is the 1 day of training. The patient received MAP. So this is one way to expand the service during during a crisis situation. What I'm going to do, I'm going to share with you a few of the cases we got during this 8 days experience. So start with a 50-year-old with diabetes, COVID, positive troponin, ARDS, obviously, hypotensive, and anuric. The patient received 2 liters in the last 24 hours and was on norepinephrine, vasopressin, and lactate was 4. So the X-ray looks wet, and these are the upper lungs, lots of B lines. Is he volume overloaded? We don't know. So let's take a look. The resident did the subcostal view. If we go from top to bottom with the subcostal, you see the pericardium on top. And then from the pericardium, you see the RV, and then the septum and the LV. For me, these look like hyperdynamic ventricles, empty, and this is a pericardial fat pad. Is this pericardial tamponade? I don't know. So we look at the IVC, and the IVC is flat. Definitely not obstructive physiology. This is most likely hypovolemic shock. So we looked at the aorta to differentiate between the IVC and the aorta. Obviously, it's part of our protocol. And we noticed this circle here full of stuff in front, on top of the aorta. We placed an NGT tube, and 1.8 liter came out. So now we understand where all this fluid this patient received. Patient has ileus. We gave 2 liters on intermittent boluses. This is the IVC after 2 liters. It's normal in size and it's collapsible. And by the way, his off pressors and lactate normalized. So this is how we utilize single view, single cardiac view combined with IVC and lungs. Let's look at another patient. 50-year-old female from New York, from city. New York City ran out of oxygen, so they start sending their patients to us via helicopters. And this is one of the patients who's ARDS with positive troponin. This is the subcostal for chamber view. Good ventricular contractility. There's no significant pericardial effusion. RV is full, contracting well. LV is contracting okay, maybe a little depressed. So we do subcostal short axis view. You can see here RV is a little bit dilated, and this is the subcostal short axis with the papillary muscles. You notice contractility is not terrible. And this is the IVC, it's plethoric. So the patient was not hypotensive or having any issues. Obviously, all of our patients will have some B lines because of the ARDS. So we stopped the IV fluid. We didn't give any IV fluid. Day 4, now you see that by keeping the patient net even, now the IVC is becoming more collapsible. And we wanted to extubate the patient in D5, so we diuresed him until the IVC became collapsible. And now if you look at the upper lungs, you can see here that there's an, let me just take this out of the way. There's A lines with some B lines. So that tells me that the wedge pressure is less than 18. So I was able to extubate the patient with no problems. Okay, let's go over another case. Another COVID-19 with ARDS received one liter in the last 24 hours, and he's on Bumix drip. X-ray was wet, so the nephrologist started Bumix, but he was not responding, anuric. So we did the daily assessment with point-of-care ultrasound. You can see here there is no pericardial effusion or very small one. You see the ventricles are hyperdynamic and empty, followed by subcostal short axis view, small ventricles. This is the RV on top. This is the donut, which is the LV. It's 100% collapsible, followed by the IVC. I don't know if you can see it, but it's almost non-existing. It's small. And the lungs, of course, a lot of B lines. So we stopped the Bumix, and we gave some fluid. We followed the IVC. It's becoming more full. And you can see after a few days, now the RV, this is another subcostal view a few days later. Now the RV is becoming dilated. it's bigger than the LV. And the IVC is becoming plethoric. At this point, we proned the patient and started the Bumix infusion. The nephrology consult or service predicted that the patient needed Bumix or diuretics days before we started. All right, I'll be running through these because I don't have a lot of time. So this is another COVID patient, hypoxic, PF ratio 150s, prone, PEEP of 10, acute kidney injury on hemofiltration, and hypotensive. So this is the subcostal view. No significant pericardial effusion. The RV is contracting well. The LV looks thick, contracts well. This is the IVC. It's kind of smallish. And this is the aorta. I just want to caution you that when you look for the IVC, the only way to differentiate between the IVC and the aorta is by finding both. See here, this looks almost like an IVC entering the right atrium, but we notice that it's below the liver, so it's deeper. But that's why I ask my residents always to identify both IVC and aorta to make sure that we're not confusing both. Anyways, by completing the exam, we see A-B pattern, where in this side, only A lines with few B, and here we have multiple B lines. Now, because I see thick ventricle, I'm not super happy only with the easy exam. So I go and I do apical 5-chamber view. I notice that there's some acceleration of flow. So I think there might be some LVOT dynamic obstruction, and the patient is probably volume behind. And what happened here is, as you see, the anterior mitral leaflet is being pulled, causing mitral regurg and acceleration of flow here. So this is SAM, systolic arterial motion. You treat that with fluid and afterload increase with phenylephrine. Let's go to the next one. 45-year-old with COVID, ARDS, AKI, chronic kidney disease, coronary artery disease, a lot of underlying chronic conditions. And she received some fluid and still hypotensive. This is the subcostal view. You don't need to be an expert to see that there is no pericardial effusion. RV is smaller than the LV, but the LV is screaming, help me, help. There's no much of contractility. You can see plethoric IVC. So, and then obviously B lines. At this point, we stopped fluid. We gave some norepinephrine and started low-dose epinephrine. We were able to get perfusion. So this is the, a lot of the septic patients will have this normal cycle. Initially, they present as hypovolemic and vasodilatory and hypovolemic. You give them volume, you optimize them, and then they become well-resuscitated vasodilatory. Some of them will develop cardiomyopathy. And I apologize, this is a little bit of old because this published in 2020, back when the thiamine and vitamin C was a thing. Right now, obviously, we don't do thiamine or vitamin C. But that patient, towards the end, if they have cardiomyopathy, then they receive after vasopressin, norepinephrine, and maybe add some inotrope and start hydrocortisone, obviously, for vasodilatory. Another case, COVID, ARDS, AKI, positive troponin. Here you see thick ventricle, but this is subcostal 5-chamber view. You notice there's some aortic calcification here in the aortic valve. And the IVC was plethoric. So before you say this patient doesn't need any more fluid, we need to think that the IVC is plethoric because maybe obstructive physiology. So here you need some critical care echocardiography. We did diastology. We look at E over E prime. The E prime was 7. E over E prime was 6. We knew that the patient's probably dry. We gave 250 twice, and we monitored with E to E prime until it was 10, and we stopped giving fluid. We just gave afterload. We give vasopressors, which is norepinephrine. Finally, I still have 2 minutes. Another COVID patient who's anuric. And the subcostal view here showed the RV is hypertrophied and it's larger than the LV, okay? And the IVC is plethoric. And the right atrium is a little bit big, but the function is good. This is the aorta, just to show you that IVC and aorta can be very misleading and they can look very similar. Then the lungs, we have some AB pattern. So started vasopressin to improve RV perfusion and added inotrope. We prone the patient to decrease the afterload and start removing volume, despite being on 2 pressors. So in this situation, some of the patients have underlying pulmonary hypertension, could be evident by right atrial enlargement and RVH. Some of these would be also have pulmonary hypertension and hypovolemia. So if you're trying to correct volume of these, you need to give smaller aliquots of fluid multiple times instead of giving large volume to optimize the filling pressure. After that, you want to optimize the pump by having vasopressin, which doesn't increase the pulmonary vascular resistance, but it can improve the LV perfusion, which is perfused during systole and diastole. So vasopressin, and then I can improve the pump and reduce the afterload by optimizing the ventilator. I might need pulmonary vasodilators, and finally, I might need to go to ECMO. So they're more complicated patients. This is one of our residents doing the pre-rounds. He looked at 2 patients. They are phenotype 2, so they're normal, but we noticed that the patient in the middle have a new RV dilation. So we started the round there, and right here, you see the RV is a little bit big as the LV. And then this is a dilated IVC, but the lungs looks clean with just AB pattern. So the RV wasn't dilated the day before. That prompted us to do Doppler to the femoral veins, and we noticed that there's bilateral DVTs. So we started low molecular weight heparin. And we noticed that after we scanned all these patients in a row, 1, 2, 3, 4, 3 out of 4 has DVTs. So early on, we start noticing that COVID patients are hypercoagulable, and we started putting a lot of them on heparin prophylactically based on the severity. This is thromboangiopathy. This patient is not on a lot of pressors, but just in a thrombotic state because of COVID. So in review, the phenotypes, you can do a subcostal view. If you do the subcostal, combine it with IVC and lung ultrasound, you can end up looking at patterns, and you can detect on chronic disease. So if you see underlying chronic condition, for instance, if you see LVH, you need to consider that this patient probably has chronic hypertension, maybe underlying aortic stenosis or undiagnosed hypertrophic obstructive cardiomyopathy or myocardial deposit. If there is any enlargement in the ventricles, then it could be that they have underlying systolic dysfunction, maybe dilated cardiomyopathy. You need to rule out valve disease. So anytime you see signs of chronic disease, you need to follow the easy exam with full critical care echo. Obviously, cluster 3, where the RV is bigger than the LV, can indicate isolated or predominant RV dysfunction, which is corpulmonally acute on chronic or acute. These are the signs of chronic disease, which is right atrial enlargement and RVH. And these patients should be treated targetedly and differently. And when you see, anytime you see these chronic disease, you should suspect them. Back to our patients in 1 week, there were 63 exams done for our residents in 14 patients that we rounded on. 87% of the time, I did not need to go into the room because I was happy with the exams, and I needed to go into the room to do my critical care echocardiography only 13% of the time. And I'll stop here. Sorry, I think I'm 1.5 minutes over time.
Yeah.
We published our experience, so you can actually, it's an open access with critical care exploration. So if you're interested, you can just, I can send you a link, and or I can send you the article.
The chat group, in the chat area, Dr. Nebras, if you don't mind, we can put the link. Yeah, it's always pleasure to hear you, Nebras, talking about the subcostal view importance in critical ill patients. And as we emphasized this several times before, for our fellows and for everyone, especially those who are joining us and not in the fellowship program, that to start with, it's very important to have everyone with any hemodynamic instability examined by point of care ultrasound, integrated tools of point of care ultrasound, heart and lung, at least, if not the abdomen as well, and DVT. And the subcostal view, as Dr. Nebras showed us in the week of EASY and now today, highlighted more on the value of subcostal view. Nebras, do you recommend to go with the subcostal view to start with? Because a lot of bedside discussions among the expert and non-expert even, where to put my probe first. So if you want to choose between the sites and you're in a hurry in a busy environment, do you go first with the subcostal?
Anybody who knows me know the answer, know what I would choose. So I would put the probe where the money is. Where can you see the IVC and the heart in the same location?
Mm-hmm.
Plus, in the ICU environment, a lot of patients are ventilated, so the lungs are expanded. It's difficult sometimes to get the apical and parasternal views, and you need to position the patients appropriately to do it. With the subcostal view, the proper position for it is supine. So I don't have to change the patient's position. I can get more information from one window. And if I know the limitations of this window, then probably I can teach it in one day. I can teach anyone to get adequate views in one day. I cannot teach them how to do interpretation in one day, but at least they could be good sonographers for that. And I think it's a good entry point. So in our institution, all interns learn only the subcostal view. They're not allowed to do the other views, so they can master the subcostal. And then at the end of academic year, we do a 3-day camp where we go over the other views, and we do critical care, echocardiography measurements, Doppler, and all that. But also, it shouldn't be done in isolation. You need to do lungs with it. And we put a lot of emphasis on completing the exam in less than 3 minutes. And this way, everybody can do their exams before rounds. And during rounds, we can together look at the examinations and do discussion and then go back and do more if needed. So for all these reasons, I think the subcostal is good opening. Plus, if you don't have the money and you don't have the probe, the phase array probe, subcostal could be done with a curvilinear probe. So if you started practice and you have only curvilinear probe, you still can do the easy exam completely with the older curvilinear probe.
Yes. Thank you, Nabas. And of course, the subcostal can answer the 4 or 5 questions for every hemodynamically unstable patient: assessment, LV, RV, IVC, pericardial effusion, yes, no, and the valves as much as we can. And of course, you should not stop at one view of the subcostal. So not only subcostal 4, not only IVC, but also you can get the short axis of left ventricle and the right ventricle, and you do the different forms of cardiac views. Thank you again, Dr. Nebras. And you're going to be with us if we have any question. We are kindly asking the fellows to raise their question in the Q&A section, and we can collect them, introduced to Dr. Nebras and Dr. Avinash later on. Dr. Avinash, you are now the frontliner, so proceed.
153 عندك الزكاة من أنت كيف طلعك؟ واللي قال
Thank you, Ashraf. So I thought about it. What should I present? How is it going to be useful for the fellows? So here it is. It's one of the real cases we had. And yes, there was a lot of learning from it as well. Yes. So 3 things that we will do with this presentation and take away home will be recognize how we use bedside echo, especially in a hypoxic patient, which is very common, hypertensive patient, which is also common in ICU setups or ED setups. The reason how Pocus can be used, how they can aid in clinical decision making, and how we can link the history as well as clinical findings. And then, of course, what do we do when we see these findings? What investigations do we order? What treatment do we do? So there's the short history. I've tried to keep it very swift. I don't want to give you a paragraph of history. Patient with end-stage renal disease. He's got this unique hero graft, as we call it. It's nothing but a very special tunnel line kind of a graft where the tip goes all the way like a PIC line into close to the SVCRA junction. This patient has a recent orthopedic surgery on a background of CKD and Hep C positive. And after 5 days of surgery, we were referred this case on the ward. The patient was hypoxic on 60% oxygen via 15 liters of non-rebreather mask on the ward. And along with that, his blood pressure was borderline, anywhere swinging between 90 systolic to 100 systolic. So the question then we need to ask ourselves, how are we going to approach this patient? Very common. I'm sure all of us have come across this kind of a scenario. I don't know if you guys can respond by speaking or chat. I'll let Ashraf sort that.
Yeah, they can share with in the chat. Yeah.
Okay, fine. As you collect response, if somebody's responding, I'll move forward in view of the time. So, of course, a few things you'll think about is it's an undifferentiated shock or pre-shock state where the blood pressure is borderline low, especially in a dialysis patient. You're thinking about hypoxia, which is sudden after surgery. The first thing that comes to your mind is, of course, venous thromboembolism, a PE. And then there are differentials. Of course, you can't rule out other reasons for shock. Is it sepsis? Is it hypovolemia? Has he lost blood somewhere? Hundreds of things. And of course, CT scanner is the best thing you can do, CTPA or CT angio, but how often is it possible with such unwell patient that you rush them to CT, risking that they may probably arrest there? One of the polls, of course, questions you can ask ourselves is, in a hypertensive, hypoxic dialysis patient where there's no access to CT, then what is your first bedside move? A lot of you might think, should we just start them on treatment or enoxaparin, wait for imaging the next day, carry on the rest of the treatment simultaneously? Do a focused echo? Is it useful? Regardless of how things are, just get the patient to CT, push, get 3 or 10 people, and then just get through. Or give a fluid bolus and assess over 30 minutes what happens to the blood pressure. Does it get better or not? So again, everybody will have different answers. That will depend on the patient. But given this history, I'll go for, sorry, where is it? Given this history, for option B, which was, of course, doing a Pocus echo. And this is a Pocus presentation, and that's why we're talking about it. So coming down, this is exactly what we see. Now, I don't know how many of you are going to identify the structures we are seeing and what view on echo this is. I'll let you have a look. I hope you can see the video clearly. Okay, anybody can think of which view this is? Is it plaques? Is it PSACs? Is it Michael 4-chamber, 5-chamber, subcostal?
I can see here some Dr. Muhammad Abdel Ghali wrote, it's a huge RV in short axis, parasternal short axis.
Yeah.
Yeah.
Okay, so this is actually a modification of plaques, which is parasternal long axis view. And this is called the RV inflow view. Again, a lot of critical care echo programs are picking this up. But how you do it is you do a normal plaques, with the pointer facing your right shoulder of the patient. And then all you do is you do tail going further upwards, as you can see in the picture on the extreme right on one of the mannequins. You're just bending it down so the tail goes further up towards the head of the patient, and that's how you get this view. And what you're seeing in this view is, of course, important. And if you're not used to this view, this is exactly what you see. You see an RA at the bottom, you see tricuspid valves, and you see RV. There's no part of the left heart seen in this case. And now I'll play the video again. Probably that will help you get oriented a little bit. as I think Mohammed has already spoken, you can clearly see that there's something abnormal in between the valves, and we'll talk about the rest in a bit. And that's how I've labeled it. Now that we've seen this, we can move to the next slide. And that is when we change the view, what did we see immediately? So all of us know this view, which is PSAX or personal short axis. Those of you who are doing echo recently or who are new to it, that's how you can look into the chambers, and that's how it will visually look. And on the left side of the screen, you can see again there's a mass which is literally jumping up and down like a chicken, which of course is funny, but not enough for the patient given how poorly the patient was. Now this gentleman, little going into history and what happened next. We got him into ICU. Of course, we started resuscitating and doing the scan simultaneously. His blood pressure is 100 systolic. Now, two things that come to your mind, given the history of surgery and everything else, you will think about PE, isn't it? And the second thing you think about is, of course, does he have infective endocarditis? It's extremely impossible to say this is just PE or this is just IE or infective endocarditis. So what we did, we continued the treatment for both. We treated him for the antibiotics for the infective endocarditis immediately, took the cultures and did all of that bit as the scan was going on. But also anticipating if this is PE and he arrests, we got the medications ready. We had our altiplase right next to the patient bedside, loaded if this needed to be given. So that helped us really, really well. Coming back to the next views, we've got the 5-chamber view. And again, those of you who are starting to use it, it's just the 4 chambers along with the aortic opening. And again, you can see on the left side of the screen, there's a circular mass popping in and out from the tricuspid valve. Now, with all of this in mind, what does it show when the probe goes down overall in the picture? I've just put one of the images that goes through the 4-chamber view and looks at the estimated pulmonary artery systolic pressure. And in this case, approximately, you can say it's around 60, 65. So things that will make us think that this is PE or going in favor of PE, of course, dilated RV, which we've seen in the images or videos that we've seen. RV similar size to the LV or bigger, hypokinetic free wall of the RV, which we've seen. And then, of course, the echogenic mass. So again, infective endocarditis cannot be ruled out, but there was something there. And more importantly, what I deliberately didn't tell you in the previous images, that there was something else that was sticking out, which I'll show in the later images, that led to the formation of this clot. So bedside impression with all of these findings clearly showed that this patient is acute cor pulmonale, and until proven otherwise, we should treat it. Now, where does Pocus sit in the shock workup? Sorry. Of course, you look at 3 things: heart, volume, vessels, very similar to what Nebraska was talking about. And in this case, the question was, is it the pipes, obstruction of the flow in the pipes? Was it the pump where the RV was failing because of everything that was happening? In fact, it was a combination of both these, and we could see this with the views that we saw on the echo. So coming back, a very quick recap. We all know what are the signs of RV strain on echo, not on ECG, of course. We've got the D sign where the RV is so dilated, bulges into the LV, and that's called ventricular interdependence. Then we've got the McConnell sign where the RV free wall of the mid region is not moving well, but the apex is hyperkinetic. You can do TAPSE if you're doing measurements with M mode, where it's less than 17, that can tell you that there is impaired RV function. Not 100%, not a very sensitive test, but yes. And then there's a 60-60 sign where you've got a PASP of less than 60, or you can say 30 to 60. Also the acceleration time reaching the peak of your tricuspid jet being around 60 milliseconds. And that is kind of a little bit more sensitive, I would say. And that brings us to the next question. Which signs of these is more specific for acute RV pressure overload, not chronic? So you've got 4 options. You've got isolated RV alone. Is it McConnell sign? Is it tricuspid regurg? Is it hyperdynamic LV cavity? It's obviously, I mean,
There's no responses here.
Yes.
Yeah, you can proceed.
Yes, I think it's obvious, and I've made the options very easy, clearly. So McConnell sign stands out of all of the things that's more specific. And all of us know about McConnell sign, isn't it? It's got good specificity for RV strain that is acute in nature, and of course,
قلبي
it's separate from the
الثاني
pulmonary hypertension, which is chronic in nature. So the turning point, of course, I've tried to summarize here. The patient deteriorated further. Unfortunately, 15 minutes after all of this, and we were still resuscitating, trying to get the blood pressure up, had a cardiac arrest. We knew because we had done the echo straight when the patient came into ICU what the problem was. Altiplase was ready, immediately administered, and we achieved ROSC within 6 minutes. So deciding factor here was high-risk PE physiology. We saw the RV strain, thrombolysis done at the right time in a high-stakes call. And unfortunately, we couldn't have any other imaging modality in this particular period of time. And that's where the echo came into use. Following the stabilization, ROSC, of course, we had done the thrombolysis, we repeated a CT, and that, of course, confirmed what we had already seen on the echo, that there was extensive bilateral PEs. Yes, we had done thrombolysis, but there were still residual features of PE elsewhere. Sorry, coming back to the origin of the clot, that's the question. Where did this clot come from? Also, to make it interesting, I've put a follow-up transesophageal echoes. And as you can see, that's the mediasophageal four-chamber view, and I've labeled it for making it easy. That's the right side, and the left side, of course, as labeled LA and LV. And you can see there is something labeled as H, and that is the hero graft, which unfortunately here had migrated down into the RA, and it had migrated to such an extent where it was hitting the tricuspid valve, constantly irritating and forming the thrombus as a result of that. That gave us the PE. Similarly, the other view where we've just seen the right side, as you can see on the right side of the image, the RA and the RV and tricuspid valve in between, you can literally see that line labeled H is the hero graft literally touching and abutting the tricuspid valve, and that was the main root cause here. So with all of this in mind, again, for comparison, now I will tell you that this H again is the hero graft which was needed for dialysis. This was pre-cardiac arrest. And this was another transthoracic echo, the same RV inflow view from blacks. There was no clot. All you see that there was hero graft still sat hitting the tricuspid valve. So now, what did we do? Overall, it was not just the acute phase. It went on to an MDT discussion where, of course, we treated the PE with thrombolysis, put him on therapeutic enoxaparin, but also had an MDT discussion with nephrology, in interventional radiology, and eventually in a safe period where, of course, patient was on anticoagulation. We reached a point where we could stop it for a brief period and then got this hero graft out, and the source of the nidus for the PE was taken out. So from rest to full recovery, it included a number of steps. Of course, there was MDT discussion, the removal of the hero graft, therapeutic anticoagulation continued, and then there was complete resolution of this PE in this case. Timeline-wise, if you're interested, I've summarized it, but like I said, the most important crux of the matter here is how did we manage this case? So 5 pearls in a patient whom you will see next, probably who will have a shock condition. Of course, do not forget the RV. Please also look at the RV. LV is not the most important part of the heart. History in this case was the vascular access, the dialysis catheter, the hero cath that was present. You may not have the time for the CT, but if you've got these deteriorating symptoms, you've got all the justified clinical steps to take with thrombolysis. And then, of course, correlate always. Don't just look at one finding, mix it up with the history and the findings. And of course, in this case, we involved multiple teams early in the stage, and that helped us with the long-term outcome of this patient. Message, if there's a shocked patient who can't go to the scanner, you bring the scanner, of course, in the form of ultrasound to the patient. And of course, if it's PE kind of a picture, the RV size and function will help you guide the next move. It is fast. Again, like Nabras was mentioning, less than 3 minutes, contextual, and you've got your information and history to some extent. And then, of course, the collaboration with different teams, which makes medicine the best thing we can do. And if you're interested in reading the full case report, you can scan the QR code, and that will take you to the article that we published. sometime last year, I think. And that has all these videos and everything in detail. You can read through, and hopefully you like it. And that brings me to the end of my presentation. Thank you so much.
Thank you very much, Dr. Avinash. Very nice presentation, full of messages, actually. And the most important message that everyone should carry home is that if you are dealing with hemodynamically unstable patient, then point of care ultrasound should come as one of the first tools to investigate your patient, because we still see this debates among the physician in acute care settings, ICU even, OR, emergency, acute medicine. We still see people arguing to go with or not to go with point of care ultrasound. Actually, you have to see the anatomy, you have to see the heart. And because there is a question here in the Q&A, which protocol you prefer, Avinash? Do you have certain protocol, or you just go and examine to answer common 5 questions, as we mentioned before with Nibras? How do you answer the question?
Absolutely, Ashraf. I think it's pointless to say somebody's fully hemodynamically stable. You may not jump in with an echo straight away. You'll do it later in the day. But somebody like this who's hypotensive, it's a shock state or borderline hypotensive, is there a harm in using? Yes. Again, don't skip your clinical examination, auscultation, everything. They are a part of your examination. Ultrasound adds on to the information you'll already receive from all of these things. But again, I don't think we delay it at any point saying, let's do it tomorrow because the patient's gone on noradrenaline. What's the point? Yes, you'll see a normal heart. That's fine. But if you pick up something, your decision making changes drastically. So majority of our cases, any new admission, anybody's hypoxic, of course, we go ahead with lung ultrasound and collaboration in combination with everything else. But anything else, there's so many instances where patients come in from theater, the lactate's going up, for example, or the blood pressure is dropping. It takes 10 minutes or less than that to do just a scan of the abdomen, the kidneys, just to see what's happening inside. So that's why I think all of us here are, together discussing this because we are pro ultrasound.
Yeah,
So, like I said, irrespective which methodology you follow.
Because we are pro of ultrasound, but also there are a lot of evidence that early point of care ultrasound resulted in a big difference in management plan to reach the diagnosis, definitive diagnosis, and maybe to change the direction of management plan to very, very high degree of extent. Dr. Nibras Bugrara, if you have any comment on this. Are you still there, Nibras? Anyway, but it's very interesting for me. A couple of days ago, I had a patient who had core pulmonary before, RV dilation before, but the history was suspicious of pulmonary embolism. When I did the exam, what I could found on top of the RV dilation and chronicity of this RV dilation, that the McConnell sign, though he had history of PE before 2 years ago, the McConnell sign was still positive. And this is, by the way, it's not clearly mentioned in the literature how far or how long the McConnell sign will stay in patient with pulmonary embolism, for example. I suspected that this could be acute, and it's confirmed by CT to be pulmonary embolism. So if you see McConnell sign, it's a specific sign and could be one of the acute signs of pulmonary embolism. Thank you again, Dr. Nibras, if you want to comment.
Yes, sorry, I was trying to figure out how to get my mic to work again. Avinash, this is an amazing case. Thank you for sharing. Regarding the answer for which protocol, as long as you have a protocol in mind that involves more than one organ, then you're good. I'm against trying to do an examination of the heart without really examining the inferior vena cava, without going to the lungs. I don't think the examination is complete without assessing the heart and lungs together with the inferior vena cava for the preloading conditions. So what we prefer here, we do the easy protocol, which is we start with the subcostal IVC upper lungs. And then anytime we see signs of chronic disease, then we go and do more views. I usually stop when I get the answer for my question. So a lot of the exams will end up with the apical 4-chamber or apical 5-chamber, and I don't go to the parasternal, because I believe point of care ultrasound needs to be point of care. And anytime you spend more than 5 minutes doing it, it's a problem, especially for us when we have busy ICUs and we have 12 patients or more to round on every day. I feel we do not need to spend a lot of time doing point of care. We'd rather just try to answer our questions specifically. The way you do this by sticking to a protocol, doing a protocol and sticking to it, and then have quality assurance performance. So you save your images, review them to learn from your mistakes. But yeah, so as many exams of the heart as you need, but you need to include the IVC and the upper lungs and pleural spaces at least.
Thank you very much, Dr. Nabras again. And time now for Dr. Hazem Lashin. And we have his presentation recorded. And Dr. Hazem Lashin is a consultant critical care medicine at Barts NHS London. And he's going to present a case of cardiogenic shock, rule of point of care ultrasound in cardiogenic shock.
Good afternoon or evening. My name is Hazem, one of the intensive care consultants at Barts Hospital, Barts Heart Center in London, United Kingdom. And I was asked to talk to you today for 15 minutes about some cases of cardiogenic shock. So I thought we'd focus on ischemic cardiogenic shock for these cases. And also we will very quickly show some complications of myocardial ischemia that can lead to cardiogenic shock. So this is case 1. Patient came in with chest pain, and this is parasternal long axis view. So in this view, you can appreciate that the septum is perhaps more hypokinetic than the infralateral wall. However, it is not very convincing. So this, based on this echo, on this picture alone, I would not say that this patient is in cardiogenic shock or has significant LV impairment. And this is parasternal short axis view of the same patient. And as you can see here, the anterior and the septum are both severely hypokinetic compared to the inferior and infralateral walls. So this is the same patient in 4-chamber view. And as you can see here, the apex is completely akinetic. Some would say even dyskinetic. However, the lower parts of the septum and the lateral walls are working okay, as well as the RV. So this is a 2-chamber view of the same patient, which also shows that the apex is dyskinetic. Inferior wall is working okay. However, the anterior wall is hypokinetic, and in the apical parts is akinetic. This is the apical 3-chamber view or long axis view, which also show that the apical akinesia. So if this patient presents with cardiogenic shock, the differential diagnosis would be left anterior descending artery infarct or Takotsubo. And the only way to differentiate between these two diseases is through coronary angiography. This is case 2. Another patient, again, came in with chest pain, and this is his parasternal long axis view. As you can see, the infralateral wall is hypokinetic, but the septum seems to be working well. This is the apical 4-chamber view of the same patient. You can see the septum is hyperkinetic compared to the akinetic lateral wall, which often happens in cardiogenic shock to compensate for the parts of the myocardium that is not working as well. This is 2-chamber view of the same patient. Inferior and anterior walls are both working well. And this is the apical 3-chamber view or long axis view. As you can see, the infralateral wall is hypokinetic and even akinetic. So the coronary artery involved here is the left circumflex artery. This is case 3. So this is another patient who came in with chest pain, hypotensive with raised lactate. So in this parasternal long axis view, it seems that the septum is working well. It's thickening and it's coming in quite nicely. However, the infralateral wall, particularly the lower part of it, maybe is hypokinetic. The bit of the RV that we can see here looks that it's working, but we'll see. We'll see what comes next. So this is a short axis view of the same patient of the LV at the level of the papillary muscles. And as you can see there, the inferior and infralateral walls are akinetic. Apical fourth chamber of the same patient. You can see the basal septum is akinetic. The rest of the septum and the apex seems to be working well. Also, the lateral wall is perhaps hypokinetic. And if you look at the RV, longitudinal function seems okay, maybe a bit impaired, but not catastrophic. But there is no radial function. The lateral wall of the RV is not coming in at all. So this is apical two-chamber view of the same patient, and as you can see, the inferior wall is not moving at all, while the anterior wall and the apex seems to be working well. This here is the apical three-chamber view of the same patient. As you can see, infralateral wall is also quite impaired compared to the anteroseptal wall. So this is a right coronary infarct. And as you may have noticed that sometimes the right coronary artery will be supplying the base of the septum, and also sometimes it will be supplying parts of the territories which are traditionally or conventionally supplied by the circumflex artery. So we'll run very quickly through some of the complications of myocardial infarction leading to cardiogenic shock. So this is perhaps the most common. As you can see there is a significant pericardial effusion around the free wall of the LV. We can't see very well around the RV. So this happens often, sometimes due to puncture of a coronary artery during primary PCI, or as an inflammatory response. And in these patients, particularly if the LV is severely impaired and the patients are in cardiogenic shock, a small amount of pericardial effusion, even half a centimeter, is enough to compromise cardiac output. And this is a common battleground between us and the cardiologists, where we say that yes, the pericardial effusion is small, but can still compromise cardiac output and cause tamponade. And as you all know, tamponade is a clinical diagnosis, not a echocardiographic one. It has a different complication, however, maybe a bit later. As you can see there, this is a very poor LV. The septum is akinetic, and the apex also is akinetic, and the whole heart is being pulled by the lateral wall. And as you can see, there's an echogenic mass in the apex. This is an LV thrombus, which is a common complication associated with apical akinesia and apical and LAD infarcts. Another case, it's as you can see in this apical four-chamber view, there is the lateral wall of the LV is akinetic, and the septum is hyperkinetic to compensate. And if you look at the mitral valve, you can see that the posterior mitral valve leaflet is flailed. So the tip of the leaflet is below the coaptation line, which suggests that it's flail rather than that it is prolapsing. And this will result in significant blood being shunted away from the LV, going out to the aortic valve, go back in the left atrium, and this will can result in some cases in cardiogenic shock. In this case, it was a result of a circumflex artery aneurysm and papillary muscle rupture, resulting in this picture. And if you look at the LV parts that are working, it gives the impression of being hyperdynamic, and this is the case because an ejection fraction, if you calculate it here, will be quite good, but this is in the context of severe MR, and that the heart is not loaded enough to show its true function, and that's why it appears hyperkinetic, as you can see. So this is one of the severe complications that can result in cardiogenic shock. This is another complication of cardiogenic shock that can result in of myocardial infarction that can result in cardiogenic shock. If you look closely at the mid septum, there is a echo-free space in the middle, which is a VSD following an anterior infarct. This patient also, if you can see there, the RV is quite poor, and that may be because of the VSD or another myocardial infarction. So this is a color flow Doppler across the septum into the RV, and as you can see there, the flow is in systole, which confirms that it is a VSD. So this also can cause cardiogenic shock by, again, diverting the blood from the LV into the RV, which will result in a decrease in the stroke volume. And if you divert enough blood into the RV would not be able to cope. The pressure will start to rise and it will fail. And that would be another mechanism for cardiogenic shock, which may be the case here. As you can see, the RV is quite impaired. This is a short axis view of the same patient. It's not the best quality, but if you look closely, you can see there's echo-free space in the septum. And this is the color flow Doppler across that septum, which also will give the can present as cardiogenic shock because of the mechanisms that we have mentioned. Thank you very much for this attention. For your attention, this was a very quick, a few cases, and I apologize that this has been recorded because there has been a mix-up in the schedule. Again, I apologize and hope to see you again. Thank you very much for your attention.
Thank you very much for Dr. Hazem for this very nice sum up of the regional motion abnormality that fits in the scenario of shock patients, and it directs the attention toward underlying coronary artery disease. And you can, based on that, to refer to cardiologists and to both management plan to intervene for acute coronary syndrome, cardiogenic shock, and also point of care ultrasound and recognizing common complications. It can be life-threatening complications of myocardial infarction. Dr. Hazem is not around for answering the question, but if you have questions, you can still put them on Q&A. Let's go now to the presentation by our fellow, and at the same time, he is one of our seniors, Dr. Anwar Yusr from Al Yemen. He's a critical care consultant, and we are very proud to have him with us in point of care ultrasound fellowship advanced module. And we also recorded the presentation of Dr. Anwar, but he is live with us if anyone asking any question directed to Dr. Anwar. Habiba, please run the presentation.
Good evening, my teacher and our colleague. Thank you very much for this chance to present my cases in our course in Pocus in shock. Our case in summary, where it started, is a case of 27 years old female, admitted 2 days post-cesarean section, complaining from chest pain and shortness of breathing from other city, not our capital city in Yemen. Chest pain associated with 3 attacks of tonic-clonic convulsion at the same day of admissions, no previous history of convulsion or anything. History of bleeding per vagina since yesterday. It's a case of 2 days post-cesarean section after complete full-term pregnancy. We start by resuscitation. As we know, this patient looks ill, conscious, no neurological deficits, but it's in shock state with severe respiratory distress. Her vital signs, blood pressure is 70/40, heart rate 110, respiratory 35, oxygen saturation 60, central venous pressure is 19 centimeters water. On admission, signs we take the history and examination, the new attacks of convulsion instead of shock. state. So we give sedation at the same time by midazolam to control the convulsion, then intubated and connected to mechanical ventilator. Patient is still in shock. We start by noradrenaline infusion. After that, we add adrenaline. But this case is in shock state. Which type of shock? We don't know. At the same, it is from bleeding per rectum hypovolemic shock, or it is obstructive shock due to post-natal state. This hair ECG we will show here is S1Q3T3. This is early signs of R right ventricular strain, and which give impression of the case is in pulmonary embolism. Problem list in summary: post cesarean section 2 days, vaginal bleeding 1 day ago, not huge amount, convulsion maybe due to eclampsia, but patient is in shock state. All the parameters of shock is oliguric, high lactate, severe metabolic acidosis, or the state of the shock. But we concentrate only on our discussion about focus. It is hypovolemic or obstructive shock. So, due to patient on mechanical ventilator, high positive pressures, difficult views on echo welding. At the same time, I bring my portable echo, Philips, and start to subcostal view. This subcostal view, I will see at the same time in emergency. I have not more experience in echo, but I see the right ventricle is larger than the left ventricle from the subcostal view. This is the video. Right ventricular enlargement. If we will see the right ventricle more than the left ventricles. Also, I will do subcostal view from the subcostal view. I will see the inferior vena cava, which is congested plethoric inferior vena cava. All these manifestations direct our diagnosis to obstructive shock, pulmonary embolism. Also, I will try to do from the parasternal long axis, and then short axis, you will see the thinning of the interventricular septum and the D shape of the left ventricle. But at the same time, I cannot take a video, but only a picture is catching D-shaped left ventricle and septal flattening with the D-shaped. All this manifestation direct us to the patient is in shock due to obstructive shock, due to pulmonary embolism. I am not take it only. Also, I consult cardiologist to confirm our diagnosis, to be on the safe side, and to make a team from the cardiologist, neurologist, intensivist, and obstetrician to take a plan for these patients, because we cannot do a thrombolytic therapy. There is a vaginal bleeding. What we can do? After that, after team discussions, what I told, about thrombolytic therapy in these patients, 2 days of vaginal bleeding, hemodynamic unstable, under sedation, mechanical or noradrenaline, adrenaline infusion. So our treatment plate, after stabilization of hemodynamic, we start heparin infusion at the same time. Intervention radiologist, after discussion with the intervention radiologist, we will direct the patient to the cath lab to make mechanical destruction of the thrombus by wires and balloon, then aspiration to make a track to the blood flow through the pulmonary arteries. We take a catheter from the femoral artery. Then local injection of alteplase after the destruction of the thrombus, continuous infusion for 48 hours. Patient return to ICU to continue the same treatment after obstruction is opening. But we cannot continue on this time with the alteplase infusion and the heparin. This is the photo from the cath when opening. We will make a new echo. This is the echo. You will see the right ventricle is smaller size than before. In this echo, this subcostal view also. improvement في acute right ventricular pressure overload or right ventricle size is used. Inferior vena cava is collapsed, not plethoric as previous. This will take video. I take the subcostal view from the apical four chambers. We will see the right ventricle is smaller size than the left ventricle. This means that the obstruction is improved, no pulmonary embolism. Patient also hemodynamically becomes stable, better right ventricular systolic functions. After that, I give boluses of IV fluid, resume of heparin by 5,000 sub-Q every 6 hours after 24 hours of holding of alteplase and heparin. And we make complete control to hemoglobin and hematocrit every 8 hours. For the patient, control abdominal ultrasound every 12 hours to calculate the amount in the pelvic, if increased or stopped. Then remove the sheath and the alteplase and the catheter. Patient is improved. Patient become better, improved after heparin. Then I go to with Kirixan 40 milligram every 12 hours. No more bleeding. It's small size of the hematoma. Patient is improved. And Sitcharg completely healing on rivaroxaban, new oral anticoagulation. From this case, with massive pulmonary embolism is time critical because shock and arrest can develop fast. Pocus support rapid bedside decision making when CT is delayed or unsafe. When we cannot do CT scan, patient is unstable, hemodynamically unstable. In an unstable patient, right ventricular strain echo strongly raises the probability of pulmonary embolism. Also, the collection of massive pulmonary Pocus right ventricular dilatation with the T-shaped of LV, McConnell sign, plethoric IVC, all this mean acute right heart strain or high suspicion for massive pulmonary embolism. After reperfusion, we make an echo to confirm improving right ventricular pressure.
Thank you very much, Dr. Anwar. I have a question to you from myself, actually. This is a very interesting case. Congratulate you for the good recovery and good case, good management, actually. And it again show how important it is to have the point of care ultrasound among the cascade of tools of investigating your unstable patient, especially those who are very critical like your patient. Very critical to move to CT. And probably in some places, there is no facility of CT angio. So it was a great case. Shock with RV strain that seemed to be acute. And this is an obstructive shock. It's an pulmonary embolism till proved otherwise. Did you try to do a DVT study in this patient?
What again? Which
DVT
doctor?
study. DVT.
No, yes, we will do Doppler, but I am not give the more details in this case because it's long cases. We do a DVT, no, normal Doppler of lower limbs.
The second question is, which needs a bit discussion, is why you give her thrombolysis after you already did a mechanical thrombectomy?
This our discussion of the team. What we make a team from the cardiology and because the massive pulmonary embolism patient is still in shock.
But did he
Our
see...
plan after discussion with the obstetrician and the cardiologist and intensivist intervention radio, he opened only just the thrombus by the wire and balloon,
okay,
just to make a track, and
okay,
then injection of local alteplase.
So it was
more
local
details,
insight, not
yes,
systematic.
no, not systematic, locally.
Okay, great.
Okay, most complication done. There is but I am more go to more details. I concentrated
So,
on
catheter
the focus.
directed thrombolysis.
As after thrombolysis, big pelvic hematoma, big bleeding,
Yeah,
rectus sheath hematoma, more problems.
yeah.
But we more this.
10 years ago, I had very similar case.
Okay.
But fortunately, she had no bleeding, and we decided as a team. And I loved to hear that you have a team meeting, an MDT decision, because such kind of cases needs a discussion with different specialties, because it's a very, very high risk to deal with.
Also, the bleeding per vagina make our restriction to not give thrombolytic systemic.
Okay.
Because of the risk of bleeding.
Dr. Nebras, if you have comment or question, or Dr. Ala or Dr. Avinash, if you have any question to Dr. Anwar, I can see here, can we use Altiblaze?
Thanks, Ashok.
Go ahead.
Yeah, I think I don't have a question, but I think it's very well done. Firstly, the whole management. If we ask the same question, saying, was there a point in doing a DVT scan? I mean, the management will probably still remain the same, because if you've seen features of PE and you're thrombolizing, be it catheter directed, even if you do the scan,
Yeah,
you're not going to change anything.
yeah.
And on top of that, the second thing, what was done here is absolutely what's come up as evidence now. So if you remember the trials which were done for PEs, the intermediate PEs especially, it was the PITHO trial, and then of course there was MOPET trial. But recently they came up with a HI PITHO trial, the high PITHO trial, and what they found was exactly the same. Patients who received lower dose of thrombolysis via the catheter or the catheter-directed thrombolysis did better, and also did not have the the risk of bleeding more. So those complications were also taken care of. So probably in this case, we were much before the guidelines came in, we knew what the problem and what the absolute solution was.
Good. Dr. Nebras, if you have any comment.
No, this is a fascinating case. Another one. This is so after thrombolytics. Now the question is, this patient was in shock, right? And we have RV strain. Doing a DVT exam, would that be, if you, let's say that you have a clot, femoral clot, would you put a filter at this point to prevent a second hit to the RV, or would you just be satisfied with the anticoagulation after? This is just, I don't think there's like evidence on this one. It's just, I want to see the what your opinions are.
The Doppler of the lower limbs is free, no DVT.
What if you find common femoral vein thrombus?
If we find after thrombolytic therapy,
Yeah.
okay, we can. If they high risk for embolization, we can do IVC filter.
Yeah, yeah. I think it's.
But we continue on heparin. We continue on anticoagulation. Patient some complication is pelvic hematoma, rectus hematoma, and handling. Stop on Altiblaze and heparin infusion. 1 day. After 2 days, we try with a small dose and control follow up for the size of the hematoma. Small size. Then we go to on heparin again.
Thank you, Dr. Anwar. Thank you very much. You want to say something, Nebras, before I go to Dr. Ala?
No, I think, that seems reasonable. If there's a big clot and we know that the RV had strain and shock, so I'm worried about the second hit, probably I'll put a filter if I see evidence of DVT. The point here today is also as having filter work, as we all know, work in the acute phase. And one of the common mistakes is forgetting to take the filter out before you're discharging the patient. So once you're done with the acute phase treatment, I think we use these retractable filters that need it. It's very important to not to forget to take it out before sending this patient to community, or have a mechanism to take it out.
Okay. Thank you, Nebras. Thank you very much, Dr. Anwar, for this very nice case. The end of this webinar will be with Dr. Ala Ghanim. And Dr. Ala Ghanim is intensivist at Sheikh Shahoot Medical City in Abu Dhabi. And we are very keen to hear you, Dr. Ala. Go ahead.
Thanks, Dr. Ashraf, to give me this opportunity to present one of our cases in daily ICU practice. The last, hopefully not the least, and hopefully this presentation will carry some educational value. I think you can hear me. Hopefully, you can see my presentation.
Yes.
So this was a case presentation for a hemodynamic collapse after line insertion. And maybe one of the main messages that how we get a tamponade without the classical textbook signs. We use the Pocus to have a guide diagnosis after complication of central venous access. So to start with, our daily practice is not always easy. This patient that it required urgent dialysis line, but she was really a fragile host, 79, renal transplant, AKI on top of CKD, bacteremia, and she required dialysis catheter for starting CRRT. She was therapeutically anticoagulated, and unfortunately, this information at the time of insertion we not know about it, but she has a prior SVC and brachiocephalic obstruction, and she has a stent in the brachiocephalic in situ, and she has documented SVC and right brachiocephalic thrombus with failed previously left arm AV fistula. Along with this, she has a limited cardiopulmonary reserve. She's known heart failure, AFib. She was previously COPD and BiPAP, and now after long ICU stay, she is tracheostomized, bed-bound, and she was recently diagnosed with MDRO bacteremia. And she's immunosuppressed in catabolic state because of the infection and because of the immunosuppressant for her previous renal transplant. So the setup stented thrombosed central vein plus full anticoagulation. So we now know that a guide wire or dilator can cause really a catastrophic complication. So immediately, or maybe a few minutes after the line insertion, right internal jugular dialysis line, during the insertion, there was resistance felt during the guide wire advancement, but at the end it went and the full catheter went in. And then immediately after, the patient has cardiovascular collapse, profound hypotension, almost pre-arrest state, require maximum vasopressors, aggressive flow devastation, hemoglobin dropped from like 70 to 59, so activated massive transfusion protocol. And now the main question that really the great value for the Pocus bedside. You have a peri-arrest patient and hemodynamic collapse after line insertion. The first thing you think about the complication from the line. So it is pneumothorax. Is it worsening of her septic shock? Maybe less likely because there is intervention and she got worse. Is it cardiogenic? Is it cardiac tamponade? No time, and patient cannot go for CT scan. So the answer had to come from the Pocus. So this is the main thing when you think. I think Dr. Walid always is mentioning the pump, tank, and pipes. So this is video, sorry, is not the best, but this was the immediate apical for chamber view that we got after the line insertion. I think it will carry a lot of discussion and debate, but what I can see here, her left ventricle, maybe it's not clear, but it was hyperdynamic, but the right side, especially the right atrium, there was complete obstruction from the outside with just slit right atrium. So what we conclude, there is no circumferential pericardial effusion to explain this crash. And the lung ultrasound, I did not able to share because I did not get the image, but we did lung ultrasound. There was no pneumothorax, sorry. And there was no clear hemothorax in the immediate lung ultrasound after the crash. But what we got is a compression of the right atrium. So this is what we thought it's happening. We have a tamponade physiology without the classic signs. So what we have is a liquidated collection in the right atrium, compressing the right atrium with shock, but the IVC was not plethoric. There was no respiratory variation. There was no right ventricular diastolic collapse, and there was no large pericardial effusion. So it's a regional tamponade localized collections that compress a single chamber, causing tamponade physiology with absence of the classic global signs, which cannot exclude pericardial tamponade. This was the official full study echo done by the echo technician and reviewed by the cardiology, and it confirmed the same finding, localized collection, and there is no other signs of tamponade. So both, they confirm the same theory. And after stabilization or some sort of stabilization for the patient, we have to take care for CT scan angio. Just we be sure we're not missing any bleeding. And this was the image from the CT scan chest angio. So first, there was no blush or active vessel injury, but there was right hemothorax with blood clots and extreme mediastinal shift to the left side. So now the theory, almost in our mind, it's mostly a guide wire or dilator injury to already extended thrombosed central vein, which cause contained hemorrhage that compress the right atrium from outside, plus a big hemorrhagic right pleural effusion, which cause the mediastinal, extreme mediastinal shift. So this extrinsic compression, it was mimic the tamponade physiology without a classic pericardial effusion. So tamponade is a physiology, not only happen with a pericardial effusion. So regional compression, loculated collection, or hematoma compress a single low pressure chamber, which is the right atrium, can cause tamponade physiology to follow. While the classic global signs was not absent, and the other mechanism was the right big hemothorax, because the right intrapleural pressure is transmitted to the heart and impairs the filling and decrease the venous return. So tamponade physiology with little or no pericardial fluid, the collary is decisive, drain the pleural space and not the pericardium. So by one probe, you're able to find that prolonged right atrial collapse over a third of the cardiac cycle is highly specific for a tamponade and needs no pericardial effusion drainage at all because it was small localized effusion, but it need to drain the right massive hemothorax. And this is what we did, and we got really the benefit from the Pocus. We drained the hemothorax with immediately improve of the hemodynamics of the patient. So now the Pocus really protected us from doing any harm. We did not do any blind pericardiocentesis. We worked in correct the coagulopathy by Rotem, and we did chest drain for the right hemothorax, and the patient start to have better hemodynamics, and we inserted femoral CVC, and we continue the ICU care. So this is the 5 Pocus peers. Collapse after central access, you need to scan first. Our mistake, we did not collect or we did not have the complete information about this patient, and this is why it was a potential harm to do a right upper chest access. And the main message that tamponade is a physiology and not a checklist. Then when you're doing your Pocus, you need to integrate the views and confirm your theory. So 2D IVC lung at the bedside, reproduce with a formal study and CT if you can. This is why we said also about the match the risk before you do the procedure. So like we said, upper chest was not really suitable for this patient. And here, Pocus guide the therapy and avoid further potential harm for the patient. This is all the evidence that I can collect about similar cases with tamponade, but without a big pericardial effusion or the classic tamponade signs. Thank you.
Thank you very much, Ala. It's a very, very nice case. Very, very interesting. And it deserves to be published, if you wish. And
yeah, sure.
There are some case presentations on left pleural effusion and tamponade. But for me, the best of my knowledge, I didn't come across right pleural effusion to cause cardiac tamponade. So we can hear from Nibras and Avinash, whoever is ready, if you want to comment, and Dr. Anwar also.
Yeah, wonderful case. I think the trouble we've had with cases like these is the posterior loculated pericardial effusions is then on the conventional views. The debate is always, if you ask the technicians or the cardiologists saying, oh, there are no signs of IVC being dilated, or there's no plethoric IVC, so it's actually not causing a problem. But I think the overall picture is the diagnosis is clinical, isn't it? At the end of the day, if it's tamponade, it's a clinical diagnosis rather than the numbers saying, is there any backflow in the IVC, is it plethoric or not? It is difficult to convince people then, saying we've ruled out every other cause for the shock. So this needs to be looked into. But yeah, wonderful case, excellently done. That's all I can say.
Yeah, I try to be fast as possible because only 10 minutes, but it was a really challenging because of the overall morbidity and the overall poor prognosis of the patient to push the surgeon to do a right chest tube because they were thinking that at the end she's not candidate for tracheotomy. So what I will do of doing the chest tube. And this is why I try to convince her based on the hemodynamics and physiology this patient is suffering because of this mediastinal shift and this big right hemothorax. Just do the chest tube to correct this mediastinal shift and tamponade physiology. Don't go further, but at least to correct what the potential harm happened from the intervention.
Dr. Nibras.
Well, congratulations. This is really fascinating case, and your gut feeling was right. Drain the pleural fluid because there are two vectors causing this tamponade. So just to note that, the loculated effusion, probably you see them more in the cardiothoracic surgery unit. They're very difficult to detect with transthoracic echo. That's why we can't rule out loculated tamponade in the cardiac surgery unit without performing a transesophageal echo.
Yeah.
For this reason. And we actually had a fatality in the past many years ago. One of our colleagues published that, which is combined pericardial tamponade and pleural effusion after induction of anesthesia. The patient was really didn't do well. So customary, what we do here is, at least at Albany, we screen our patients with ultrasound. And then if there's large pleural effusion, we talk to the thoracic surgeon, and a lot of times they're willing to put the pleural catheter in before induction, or before we do provide any sedation for the pericardiocentesis. Sometimes you get a lot of resistance, but for us who are intensivists, we usually say, hey, if you don't want to put the chest tube or the pigtail catheter, I will do it. So then that usually says, okay, they will get it done. But two vectors compressing the RV or RA, it's too much, and at least you can buy yourself some time by draining the pleural fluid first, because it's the low-hanging fruit.
But yeah, if this is a clot or a small effusion outside the RA, then patient wouldn't improve after the intercostal tube, is it?
No, but it will reduce the hemodynamic disturbance, because you still need to, this patient might need to go back to the OR for, especially if you see something like this, it's an automatic need to go back for cardiac surgery.
It was actually massive hemorrhagic.
Mm-hmm.
Or pleural effusion. It was massive as per the CT. So, Dr. Avinash, you raise your hand.
Yes, I think I also wanted to just add in here. When a lot of us start doing Pocus, I mean, as Nibras was rightly mentioning, don't look at one finding in isolation. And especially when we start. A lot of people start with IVC because it's a little easier to learn. And then a lot of decision making is based on IVC. Be it saying, oh, somebody's going to be fluid responsive, IVC is collapsing. Or a case like what Allah's presented here, saying the IVC is not plethoric, it's not dilated, so less likely this is tamponade physiology. I think that's where there's been a lot of debate, a lot of publications saying, where is the sensitivity of IVC in isolation to predict all of these things that we've discussed? And in isolation, at least in my personal practice, it's a very bad test, be it for fluid responsiveness or any other, because ICU patients, especially when they are on mechanical ventilation and everything else that's going on, with, of course, deranged physiology on the left side or the right side or the valvular pathologies, it's always very difficult to rely just on IVC. But when we combine that with everything else, it can give us more information than what we could see clinically.
Thank you very much again. Dr. Ala, if you go through the chat box and see an Q&A to answer some question, refer to you kindly, because we have to conclude the session
Sure.
now.
Yeah, definitely.
It's my pleasure again to have all of you tonight. Thank you very much, Dr. Nibras Bugrera, Dr. Avinash, Dr. Hazem, of course, Dr. Anwar Yusr, and Dr. Ala Ghanem. A special thank to ICOM company, Mr. Ala and Mrs. Habiba, and also for WICCEM and Dr. Amr Al-Husseini. It's a pleasure to meet with you tonight, and wishing to seeing you very soon in the next live webinar in week number 20. The next batch of the program will be all about transesophageal echo. As Dr. Nibras said, there are certain conditions in ITU or an ICU that if even the transthoracic echo is doable, feasible, and accessible, but negative, doesn't rule out the pathology you might think of. So you need to know some basic knowledge of transesophageal echo. That's why we have 4 weeks of dedicated transesophageal echo. If you are interested in the program, just visit the wiccem.org/Pocus fellowship, and you can find the information you wish to see, or you can drop me a message on WhatsApp or Facebook, LinkedIn, anywhere. Thank you very much again. Hopefully you finished answering the questions, or should I close the session? You finished? Anyway, if you have any question,
I'm doing writing. You can close the section. I'm not sure if I'll be able to write still, but
we have a
I will just keep online till I'll finish it.
Yeah, we have the very active WhatsApp group, or you can use the email to reach all of us.
Yeah, sure.
Thank you very much again. Nice to have you, all of you. Thank you very much. Bye-bye.
Thank you. Have a nice evening. Good night.
Same for you. Bye-bye.
See you, everyone. Thank you. Bye-bye.
Thank you all. Have a good night.